Hello, friends. So, I'll be giving a brief overview on this subject TTP, thrombotic thrombocytopenic purpura. I'm sure many of the intensivists might have dealt with these cases. So, just a brief overview, and of course, we'll have some few MCQs after this. So, we wish to acknowledge Dr. Swati and Dr. Rashekar, who helps develop this consent. So, as you know, TTP is a syndromic condition, and mortality can be pretty high if untreated. And it is good to have clarity on how to diagnose this and have a high index of suspicion when you encounter an ICU patient with certain symptoms. So typically, when you look at TTP, it consists of pentad of symptoms. So it consists of five typical hallmark features. So the first one is it patients tend to have fever, so they should have fever and thrombocytopenia. So they have low platelets. And the key hallmark is they will have hemolysis. So there is a MAHA, microangiopathic hemolytic anemia, or so hemoglobin can be low and they will have evidence of hemolysis. And the hallmark aspect is they would have neurological dysfunction. They can present with confusion, coma, seizures, or focal neurological deficits, so on and so forth. And the fifth sort of a dysfunction that prevails is the renal dysfunction. So this is the pentad. So the pentad symptoms is a typical characteristic of TTP. So this is something all trainees should possibly bear in mind. If you have any patients coming to ICU with any of these organ dysfunction, with evidence of hemolysis, with obtundation or neurological symptoms, at least send a peripheral smear and look out for possible TTP. So the key aspect of understanding TTP is its pathophysiology. So, as you know, there is the TTPs typically have a deficient ADAM TS13. So that is the variable that is deficient. And what is the function of ADAM TS13? So the ADAM TS basically it cleaves it and inactivates von Willebrand factor. So as you know, in the circulation, the platelets attach to von Willebrand factor and they form a clot. So the function of normally we all have ADAM TS13. The ADAM TS13 tends to inactivate by cleaving. It cuts the von Willebrand factor and makes it into fragments and inactivates it. By inactivating, the formation of thrombus within the circulation is avoided or mitigated or averted. So that is so normally all of us should have ADAM TS13, which is continuously cleaving the von Willebrand factor so that this clot formation is not happening. So any patient where your ADAM TS13 is deficient, then this whole process of cleaving and inactivation of von Willebrand factor does not happen and clot formation can tend to happen. So because there is no cleaving, so there are these large von Willebrand factors which gets accumulated in the blood and they form clots in the circulation. So this is called, that's why it's called macroangiopathic hemolysis with clot formation. There is a lot of microthrombi formation because von Willebrand factor is not cleaved and they all attach to the platelets and form the platelet-based clot within the circulation. So this is the clarity that every intensivist should have as to what happens in TTP. So this is just another pictorial representation. So your von Willebrand factor is produced by these Weibel pellet bodies, and this is ADAM TS13. As you see, this breaks the von Willebrand factor and creates into polymers, and so that there's adhesion of platelets to this does not happen. In TTP, as you see, there is no cleaving process of platelets. So this von Willebrand is not cleaved or broken down. So that's why it tends to cause clumps by attaching to the platelets. Just showing different pictures. So as you see, the ADAM TS13 has to cleave von Willebrand factor so that platelets don't adhere to this, and there is free flow of the blood happens. So if there is ADAM TS13 deficiency, these long strands of von Willebrand factor are not cleaved, and all the platelets get adhered, and this causes microthrombi within the circulation. So this is the typical pathognomonic or pathophysiological aspects that tends to happen. So the key aspect is diagnostic sort of entity is in determining the ADAM TS13 activity. So when there is ADAM TS13 activity which is deficient, and the deficiency we say it becomes significant when activity is less than 10%. This happens due to the mutation in the ADAMTS13 gene. So this is a genetic representation where there is a mutation in the gene, and it can happen as a congenital sort of a deficiency of ADAMTS13 due to genetic mutations that tends to happen. It is called Upshur-Spulman syndrome. Or they can, for due to any environmental trigger or any sort of a triggers which we'll talk about, can produce antibodies against this ADAMTS13. So either it is mutation in the gene ADAMTS13G or antibodies against the ADAMTS13, which can lead to deficiency or malfunction, and the ADAMTS13 activity comes down, and von Willebrand factors are not sort of broken down. So basically, when it is not broken down, there is increase in this large and super adhesive von Willebrand. So von Willebrand factors are generally sticky and they attract all the platelets which stick to this. So the large, these are called macropolymers. There's a large polymers of the von Willebrand factors which are ultra large and they become very sticky, and platelets stick to this, and that leads to the clot formation within the vessels. And because there is extensive clot formation, so as you see this pictorial, there is microangiopathic hematosis. So all these strands, basically there are like cobwebs that are created in the vessels, and all the red blood cells stuck in the cobwebs, and there is hemolysis that tends to happen. Because the red cells are getting hemolyzed, getting stuck into these cobwebs of von Willebrand factor, there is schistocytes, because the broken down RBCs get deformed and they are called schistocytes. Because there is obstruction of the blood flow, because of this hemolysis and obstruction within the vessels, there is visceral ischemia that sets in. And schistocytes, they look like this. These are broken red blood cells and deformed red blood cells because of red blood cells getting clogged in the cobweb that is formed by von Willebrand factor and the platelets. So this is the pathognomonic hallmark of pathophysiological understanding of TTP that we all should have. So just quickly look into the epidemiology. So plasma ADAMTS13, if it is less than 10 units per deciliter or less than 10%, this is a typical hallmark of TTP. So it's a rare condition. It's a very rare condition. Annual incidence is 1.5 to 6 per million per year. So for 10 lakhs, 1 to 6 people can have this TTP. And 90% of this tends to occur in adults. And it is more common in females. It is 2 to 3 times higher in females, especially the immune-mediated TTP is higher in females. And congenital TTP tends to occur in less than 10%, less than 10 years of age. As I said, due to mutation in the ADAMTS13 that tends to happen. So the triggers are important. So there are certain triggers which produces antibodies against ADAMTS13. It can be any viral infection. The typical viral infections are Epstein-Barr virus or HIV infections, which can lead to a trigger in causing antibodies to ADAMTS13, or it can be sepsis, which we typically see in ICU. And there are a lot of drugs, mainly the immunosuppressant like cyclosporine, which is used in renal transplant. Quinine can cause ADAMTS13 antibodies or deficient, or they can act as a trigger. So tacrolimus or ticlopidine, and chemotherapy drugs like cisplatin, bleomycin, and gemcitabine. So these are all, so any cancer patients, cancer itself can act as a trigger for antibodies against ADAMTS13 or certain chemotherapeutic drugs, and these are the ones which are identified. And autoimmune conditions like SLE or any solid organ tumors in the body or hematological malignancy also can act as a trigger for producing schistocytes or TTP. And solid organ transplants or bone marrow transplants, typically BMT, they can act as a trigger for TTP by producing antibodies. So these are some of the established triggers that are referenced in the literature. And pregnancy also is one of the trigger for causing antibodies and TTP. So when you look at the clinical features, so there is a Oklahoma registry, which is the large registry for TTP. They have identified percentage-wise occurrence of clinical features in TTP, and it can be very variable. The clinical features can be diffuse and variable, but the pentad features, which I mentioned, occurs actually in less than 5%. Although it is cited as a typical pentad, not necessarily will have all these pentad features in TTP, and many a times the clinical features can be very vague. In fact, the Oklahoma registry has shown abdominal symptoms are found to be the commonest. So 69% of them can have just abdominal pain, and they can have some sort of a pancreatitis. So for all intensives, if you have pancreatitis, at least send peripheral smear, because this is also cited as one of the commonest presentation. Weakness is the second common. 63% of these patients tend to have weakness. And you have this, since it is thrombotic thrombocytopenic purpura, you have skin lesions. So you can have ecchymatic patches or purpuric lesions in 54%. Neurological symptoms like confusion, coma, seizures tend to occur more commonly in 41%, but the stroke, which is the commonest one on headache, the percentage is variable from 26 to 41% is the neurological manifestation. Fever occurs is only 10% of the patients. This is from the Oklahoma registry. So these are typical. So clinical features can be quite, the spectrum can be quite wide, but the pentad features is what you typically look with. But when you look at symptomology, it is quite bizarre. So the abdominal symptoms followed by weakness and skin lesions appear common, followed by neurological manifestations. So when you look at lab abnormalities, look into that hemolysis as the main. So MAHA, which is microangiopathic hemolysis, is very common. And obviously there is hemolysis, there is increase in LDH, and there is increase in the indirect bilirubin, and peripheral smear shows cystocytes. There will be low platelets because there is hemolysis, there is increased LDH, increased bilirubin, and they have very low haptoglobin, because haptoglobin is the one that you need, which is produced in the liver, which tries to act as a scavenger for all the hemoglobin that comes out of the hemolysis. And they're usually negative for direct Coombs test, and they're negative for DIC workup. The hallmark feature of TTP is coax are normal. So in DIC, you will have deranged INR, APTT, and low platelets. Here there is low platelets, but coax will be normal. PT, APTT are normal, and they have increased reticulocytosis. So there is increase in the reticulocytes in the TTP. So I'm going to obviously have MCQs, so pay attention. And Adam TS13 activity is the clinching diagnostic pathognomonic feature of TTP. It should be less than 10%, and very often we had one patient recently, that's why we are reviewing this literature. This patient had 3% as a Adam TS13. So Adam TS13 is the confirmation for TTP. So there's something called plasmic score. So this plasmic score was based on the study done in 216 patients of TTP from the US group, and they came out with this plasmic score. Higher the plasmic score, higher is the possibility of them having TTP. So constituents of plasmic score are all the diagnostic modalities I have said. So platelet should be less than 30,000. Reticulocyte count should be more than 2.5%. Haptoglobin should be very low, because haptoglobin, as I said, is the one that you need for scavenging. Because there is so much used in scavenging this hemoglobin, haptoglobin is very low or undetectable. And mean corpuscular volume should be less than 90. INR, as I said, are normal. In TTP should be less than 1.5. Serum creatinine should be less than 2 milligram. And there should not be evidence of cancer, because cancer also can mimic the presence of TTP. And patients should not have had solid organ transplant. So they have looked into the statistics. If the score is 7, then 96.2%. So there are 8 variables. If the score is 7, 96.2% had low Adam TS13 activity. If 5 to 6, in this particular study of 216 patients, where plasmic score was divided, if score was 5 to 6, Adam TS13 was low in 56.8%. And if score was 0 to 4, the deficient Adam TS13 was present in 4 points. So in that way, there was a reasonable correlation with high plasmic score and the reduction of Adam TS13. So when it comes to treatment, I won't dwell into all the key aspects of treatment. I'll just tell you all the modalities that are there and the sort of evidence that is there. The first line of treatment is plasma exchange. For TTP, because it is an antibodies against Adam TS3, the first sort of a treatment modality is plasma exchange. And the recommendation now is, along with plasma exchange, pulse dose methylprednisolone should be given for 3 days, followed by tapering dose of corticosteroids. So this is the second modality, and both have to be looked at as a first choice and has to be used in concurrently along with it as per the recommendation. And rituximab is something that can be considered if they are refractory to these therapies. Alternate immunosuppressives that have been tried is cyclosporin A or bortezomib, which is against the plasma cell. So it is a drug that acts against the plasma cell, which produces antibodies. And cyclophosphamide and even splenectomy. These are all the alternate immunosuppressive sort of a modalities that are utilized. And surprisingly, acetylcysteine is shown to have some benefit in some anecdotal reports because this tends to break the von Willebrand factor and helps to break the polymers and fragment the von Willebrand, like how we use N-acetylcysteine as a mucolytic agent, something like that. N-acetylcysteine as an IV formulation has shown to break the von Willebrand factor, and this has shown to have some effect in anecdotal reports. And there are new agents. This is the structure of von Willebrand factor. There are agents which work against the anti von Willebrand factor. So one of the drugs that has been used is caplacizumab, 10 mg as a bolus that is given and followed by 10 mg later. So there are two trials which have shown positive results. These are agents which work against the von Willebrand. So there is a Titan trial and Hercules trial which has shown benefit with the use of anti-von Willebrand factor. And there are emerging new anti-von Willebrand factor like ERC1779. These are all biological agents. There is DNA aptamer, and there is recombinant ADAM-TS13 that is developed called BAX930. So these are all newer, evolving sort of a anti-von Willebrand sort of a factors where some trials are happening. So I won't dwell into all those details of the trial because we would leave this to hematology to handle this. But for intensivists, Plex and pulse dose methylpredate for 3 days has to be started at the outset, followed by the weaning dose. If they're refractory to this, then rituximab is added. And the plasma exchange is usually with the 1.5 volume of the plasma is what is started. And if they're refractory, one tends to increase the volume to even twice the plasma and so on and so forth. So we've had few challenging cases of TTP. And in fact, we had one doctor surgeon, one of my good friend who had a very refractory TTP a few years back who succumbed to TTP. So it can be a lethal condition. If you do not treat, the mortality is almost 100%. So the key aspect is to recognize it, have high index of suspicion. If peripheral smear shows cystocytes and you have this pentad features of thrombocytopenia and obtundation, renal dysfunction, fever, and evidence of hemolysis, one has to send for ADAM-TS13 and then treat immediately, because without treatment, mortality becomes 100%. So that's about the brief overview. Hope there was a good clarity on TTP. So we'll move to now the interesting part, which is the MCQ bit. So I have my 5 trainees sitting. So I'll be asking them, and I think they're all enthusiastic. So I'm sure they'll get all the answers right. So very easy questions if you have paid attention, because some of the trainees, they may be a little groggy. If they have not paid attention, they won't be answering. Otherwise, it's very easy questions. So to Dr. Shastri, who is sitting with me, what is the primary pathophysiology of TTP? Decreased production of platelets by the bone marrow, autoantibody mediated deficiency of ADAM-TS13, increased destruction of red blood cells due to infection, decreased synthesis of von Willebrand factor. Shastri. Oh, Shastri has got it right. So fantastic. So says the B is the right answer. Has got it right. So now I have this question to Dr. Flohini, who is sitting here. Which of the following factors is most commonly associated with the development of TTP? Vitamin K deficiency, genetic mutations affecting von Willebrand factor cleaving protease, prolonged use of anticoagulation, or systemic lupus erythematosus.
B.
Sorry? B?
Which condition?
Which of the following factors is most commonly associated with the development of TTP? Oh, she's got it wrong. Vessel is a trigger. It is B, genetic mutations affecting von Willebrand. So possibly she is tired after the long rounds, and I think she's possibly missed out on this. So we'll move to the next question. Which of the following is not a characteristic feature of the classic pentad of TTP? This goes to Dr. Swati. Thrombocytopenia, microangiopathic hemolytic anemia, renal failure, deep vein thrombosis. Swati. Sorry? Oh, she's got it right. I thought this was a tricky question. So deep vein thrombosis does not happen. It is mainly arterial thrombosis that tends to happen. They can have strokes, so on and so forth. So I think she's a physician. So in fact, she helped me develop this content. So she's got it right. So then the question goes to Dr. Arul, who is sitting here with us. Which diagnostic finding is typically associated with TTP? Low haptoglobin levels and cystocytes on peripheral blood smear, elevated fibrinogen and decreased D-dimer, prolonged PT, APTT, elevated platelet, and normal lactic dehydrogenase. Dr. Arul. Oh, yeah, Arun has got it right. Although he had done a night duty, he's got it right. So it's A level, low haptoglobin level and cystocytes on peripheral blood smear. So very good, Arun. Fantastic. So now it goes to Shastri again. What is the first line treatment of TTP? Heparin infusion, corticosteroids and rituximab, plasma exchange and corticosteroids, splenectomy.
C, sir.
Sorry?
C.
Okay, got it right. C. So everyone is answering right. So very easy MCQs. What laboratory test confirms severe Adam TS13 deficiency in TTP? Platelet aggregation test, Adam TS13 activity assay, Coombs test, bone marrow. Dr. Flohini. What is it?
P. Adams.
Very good. She's got it right. After she got the first one wrong, she's got the second one right. Fantastic. Which of the following is a distinguishing feature between TTP and disseminated? Answer goes to Dr. Swati. Presence of cystocytes on blood smear, normal coagulation studies in TTP, thrombocytopenia in both conditions, elevated fibrin degradation products in TTP. Swati. Which of the following is a distinguishing feature?
P.
Fantastic. She's got the right answer, B. So, because that is the clinching differentiator between DIC and TTP, because TTP has a normal coagulation, normal PT, APTT. What is the potential serious complications of untreated TTP? Question goes to Benjamin. What is the potential serious complication of untreated? Pulmonary embolism, ischemic stroke, myocardial infection, gastric hemorrhage. Benjamin. Potential serious complication. Oh, he's got it wrong. Benjamin is not focusing. It's a ischemic stroke. So ischemic stroke is the because they have arterial. I saw neurological manifestations up to 46%. They are the common. Where did I say pulmonary embolism? I never even mentioned pulmonary embolism. So Benjamin is not focusing. So Benjamin is lost. So because I said neurological manifestation is 46%. So this possibly is the last question. Which statement accurately describes the prognosis of TTP with appropriate treatment? The condition is always fatal despite treatment. The prognosis is poor and patients often require long-term dialysis. With prompt treatment, the majority of patients can achieve remission. The survival rate is similar to patients without any patient. Flohini.
C.
Oh, Flohini's got it right. Yes, with treatment, majority of patients do improve, and our patient very nicely. See, our patient who is in ICU right now, she came with a stroke. She came with a left hemiparesis with obtundation, and we started plasma exchange immediately with cortico. Now her neurological deficit has fully improved. That's why, Benjamin, I tell you to focus. We had our patients with a stroke, and you said pulmonary embolism. So this is the problem with our trainees. Although we had a patients we treated with a stroke, our deficits improved. He's answering wrong. So please pay attention, correlate with our clinical context. So thank you, friends. Hope you had a good time with us MCQs. I request you all to submit your valuable work to Journal of Acute Care, and obviously can visit my website to rehear to this. Thank you. Thank you, Mandu.